Hello friends, my name is Dr. Bhargav Gaikwad. I've done my MD in community medicine and my second master's is in development studies from the Institute of Development Studies. I'm currently working as an assistant professor at Dr. Patil Medical College, Hospital and Research Center. I'll be speaking on pandemic of fear, considering the whole panic situation that we are facing right now in the general population. My intention is to present some of the facts and figures in front of you. But before, I would like to thank Honorable Vice Chancellor, Professor Karmarkar Sir from Savitribai Phule Pune University, Honorable Director HRDC, Professor Sanjeev Sonone Sir, Principal KTHM College, Dr. V.B. Gaikwad Sir, and Coordinator Dr. Vasant Borosde Sir. So coming to the scope of this presentation, I'll first brief you on the novel coronavirus and the disease it causes, that is COVID-19. Then the second session, I'll speak on the fear of infection, wherein I'll give you a brief analysis of origins of this fear in the Indian Peninsula. Then the third section, I'll speak about the implications of the fears. And when we have this background of the origin and the implications of fear, we'll try and dig into the actual disease in itself, trying to understand the recent updates and the recent knowledge that we have about the novel coronavirus. Then the fifth section, I'll speak about the India's all-cause mortality. What are the most common diseases or the infections, especially the infectious diseases that are the leading cause of mortality in India, and what are the implications of focusing on COVID-19 when we look at the India's all-cause mortality. In the key concern section, I'll speak about the alarming questions that we are facing right now and how do we look at it. And in the last section, we'll look at the way forward. Now, coming to the introduction of the COVID-19, the first case was reported in the late December in China, but a 55-year-old individual from the Hubei province in China may have been the first person to have contracted COVID-19, and it dates back to 17th November 2019 as per the data from the South China Morning Post, and this is more than 1 month before the first case was reported. There are conspiracy theories about it. It was originated in animal market or from the other sources. I'm not going into details of that. So it's a respiratory tract infection and it spreads from the droplets. So whenever you cough or sneeze or speak, the virus will be carried away with the droplet infection and will be transmitted to the another individual through the direct contact or the indirect contact. The indirect contact also occurs through the infected surfaces. So whenever droplets settle onto the infected surfaces and another individual contacts the same surface, then the virus will be transmitted if he or she touches the uh, hand to the nose, mouth, or the eyes. But to what extent the indirect transmission will play a role in transmission is again debatable. The percentage of or the dose of because in most of the research studies, the dose for the indirect transmission to the contact surfaces in the in-house studies was taken full, which may not be the possibility in every case. Another mode of transmission which was speculated in the initial period was the fecal-oral transmission, that is through feces. There is no doubt that the virus is transmitted through the feces for a considerable period of time, but to what extent it transmits from the fecal-oral route to the another person, there is no evidence as per the WHO documents. The high-risk population for this COVID-19 disease is older adults and people with underlying medical conditions, especially the uncontrolled medical conditions like diabetes, uh, hypertension, renal failure, cancer, immunocompromised states. Another characteristic about the virus is almost 80% of the people do not have any symptom, and although it differs between different regions within the country, or for that matter, different continents, it is approximately 80%, according to the evidence that we have right now. Now, since the virus is novel, that is new, it was assumed that there are going to be uncertainties. So we didn't knew anything initially when the virus was there in the China. When it started traveling to the different parts of the world, the different research communities were involved and trying to understand the disease in a better manner. But what was associated with the anxiety, what was associated with the uncertainty right from the beginning was the anxiety about the virus, and it traveled all across the world along with the virus. Now, the another factor that provoked the fear about the virus was the statistical models, especially the Imperial College London model, which speculated a lot of deaths because of virus. Two problems that we have as far as the assumptions of the assumptions of the models were concerned. One, they were completely dependent upon the data available in the developed world, especially Italy, Spain, and US. And second, it was assumed in these models that without the containment strategies that like lockdown, people will not follow any social distancing measure or the using a mask or the different strategies that were postulated initially. So these were the two important concern that we had. Now, in the development, the age structure was different, the health systems were different, so we cannot straight away replicate it to the third world countries. And the immediate impact of the statistical model, the Imperial College London model, was the Britain's turnaround for the containment strategy. So Britain initially went for the herd immunity model, wherein they thought that almost 60% of the population should be infected initially. And the second aspect of that was that the human behavior scientist advised that right now there is no peak, and if we try and restrict people to their houses, then they'll be frustrated over a period of time and will come out when there will be a peak. So these were the two concerns, or for that matter, these were the two things that were important for their decision making. But after this model, they immediately turn around to the containment strategies like lockdown. Now, what was India's situation while this was happening? Initially, there was ignorance initially from the because the virus has not come to us, so we were uh, more of in the spectator position, looking at the journey of the virus at different in the different countries. So we were not that bothered about the virus initially, but when the deaths in Italy and United started rising, it literally created a lot of alarm at the global level. But before looking at the deaths in Italy and United States of America, it is important to look at their age structures. So in the first or the upper half of this slide is the Italy and United States, and the lower half we have India and Bangladesh from the Indian Peninsula. If you look at the age structure, uh, for example, in the Italy, the more than 65% people who are more than 65 years age are 22%, whereas in India it's just 6.3%. So the older age population is the characteristics for the Italy and United States, but in India and Bangladesh, or for that matter, Pakistan, Sri Lanka, the younger population is the characteristics. And since asymptomatic infections are there in the 80% of the population, the younger population is the biggest benefit that we have right now. But the deaths in Italy and United States of America create a lot of panic in the third world countries. Then the failure of communication was the key concern. Although there was uncertainty, it should have been communicated that there are going to be uncertainties. Besides that, if because it was not communicated, the people looked at governments changing policies as their confusion, wherein it was bound to happen because of the uncertainty about the new knowledge that is coming up at the global as well as regional level. But it was not just the failure of communication from the global as well as local policymakers of the agencies, health agencies, but it was also because of the conventional media as well as the social media, that the constant bombarding of the news and sometimes the fake news created a lot of panic amongst the general population. The lack of community participation in the implementing strategies was a minor component, but it was important to improve the trust between the government policies, uh, these shopping malls, which was also the scenario in the United States of America. But rather than going into this acceptance about the virus, which was not that severe but was perceived as severe because of failure of communication, we went into a denial mode, and that created a lot of panic about the virus. Now, what were the implications of this fear? The most important implication is the fear of quarantine. Right now, we have now, since 80% of the 80% of the infections are in the asymptomatic individuals, because of the contact tracing, not just the positive individuals, but the others are also quarantined into the institutional institutions. So this institutional quarantine has again raised quite a lot of alarm and put the people on the back foot because of the fear of quarantine. So the people might come late to the institutions. So those who need the systems more might not get the benefit out of it because the systems will be flooded with the people over a period of time. So quarantine policies, although most of the states came up with the home quarantine as the important policy for the asymptomatic and mild symptomatic individuals, it will be the key in the next coming months. Second was the fear of among healthcare providers, which was not there which was a reflection of the fear among the general population, and which was not there in the 2009 swine flu pandemic, but it was seen on a quite unprecedented manner in this pandemic. This will definitely have its implication on the treatment part and the way healthcare providers will look at the patients, and this can only be overcome with the by reducing the fear among the general population. Now, third component is that the states are quite concerned about the lives versus the economy. What is the deal that we'll have to save either lives or the economy? The fear has definitely put the most of the policy makers and the statements to go towards the lives because of the deaths that were postulated by most of the statistical models. But you'll have to remember that if the economy is devastated, then the economy will also take care of take the younger people along with it through the economic depression. So we'll have to remember it's not just the lives versus economy, but it's going to be lives versus life. The fourth part is the collateral damage it causes, not just to the economy but the other diseases, uh, or the patients who are suffering from the other ailments, be it a cancer, be it diabetes, be it a heart attack. They'll not get the efficient treatment because of our focus on the COVID 19. So, because we have dedicated most of our hospitals to the COVID 19, it's important uh, that we'll have to pay enough attention to the patients who are suffering from the other diseases. Uh, the worst impact of the implication of fear of the coronavirus was the stigmatizing that we have done with the patients who are suffering from the COVID 19. And this will also add uh, burden to the existing fear of quarantine that we have. So, if a person who is head of the family and he fears that he could have the COVID 19, he will not go for a testing because of the stigma that we'll have to face in the community, not just in the community, but the family itself. So that is something that was the worst outcome of the fear of COVID 19. And all these factors collectively increase the distrust between the community and state and will affect the functioning of the state to to institutionalize or to implement different measures or the reforms that they are going to take in coming years or coming months, not for the not just for the COVID, but the other sectors that they might have to intervene, considering the economy, the state of economy right now. Now, if we have to understand the disease, we'll have to look at the antigenic testing and the antibody testing first. So the conventional test that we are doing for diagnosis is the RT-PCR test, that is the gold standard test for diagnosis of COVID-19. While antibody testing, so any virus which comes into our body develops some of the antibodies, uh, and these antibodies will protect the further infection in the if you have antibodies in your body, especially the IgG antibodies, then that means that you have a prior infection. So if you have to survey, in an infection wherein like 80%, almost 80% are asymptomatic, you can go for testing each and every individual. So the random population survey in the for the antibodies might give you a sense of how much of population is already infected with the virus. So initially, the hospital-based studies were done. So the studies were done in the hospital settings. Because of that, the case fatality rate, that is, the total number of deaths because of the virus upon total number of infections or total number of cases of the COVID-19 virus, it was quite high because all the studies were done in the hospital settings. But then later, the community-based studies came up. The New York State survey found that 21.2% of the state population is already infected with the virus, whereas the Santa Clara County in California estimated that around 2.5% to 4.2% of the population is already infected with the virus. Now, although it's a huge range between the two different counties in the same country, that is United States of America, what was remarkable was that as compared to the measured cases, that is the total cases that the state were recording, the total infected population in the community was 50 to 85 times more. And this was something that changed completely the way we looked at the case fatality rate, because now we have to look at the infection fatality rate. So if the total population that was infected but did not show any symptom, it was quite higher, which was so the denominator increased by almost 50 to 85 times. and hence these infection fatality rate then came down to zero point 0.04, zero point 0.05, sometimes zero point 0.1, zero point 0.1. Yeah. So the infection fatality rate, if you look at the current estimates in India, ICMR in their recent seroprevalence survey, that is the antibody survey in the community in different parts of the country, postulated that the fatality rate in India is 0.08%. If we count, if we go through the antibody surveys in the containment zones, that might come down to even lower levels. So that is the key thing, and that's the highlight of this presentation, that the disease is not that severe. Even flu has a higher mortality rate than this. Another myth is that the children will be affected, or for that matter, pregnant women. All the data suggests that the children mortality is almost negligible, and same is the case with the pregnant women. In youth, the mortality is less than 0.05, but the problem is with the comorbidities. So if there are comorbidities and uncontrolled comorbidities, then that is something that we'll have to screen for. But otherwise, children and pregnant women, there is no issue at all. If you look at this graph, in the upper section, we have all-cause mortality in India, and in the lower part of this slide, we have all-cause mortality in the developed countries. So here I would like to have your attention on this pink area, which depicts the mortality because of the infections, especially the neonatal mortality. This is LRI is the lower respiratory tract infections. Tuberculosis has the higher burden, diarrhea. So this is something that is not there, except from the fact that LRI, the low respiratory infections, the influenza is the most common cause, or the flu season is the most common cause of mortality, one of the cause of mortality in the developed countries. Whereas the blue area suggests the non-communicable diseases or the non-infectious diseases. But this is something that is the important part: malaria, hepatitis, so typhoid and paratyphoid. So these are the important elements that we cannot ignore while focusing on the novel coronavirus. Now these are the most important causes of deaths in India: neonatal disorders, ischemic heart disease, that is heart attack, low respiratory tract infections, diarrheal diseases, chronic obstructive pulmonary disorders, stroke, tuberculosis. This red or the orange box suggests that it is statistically different. The difference between the group mean, that is between the lower, so the second row suggests that these are the figure from the average figures from the low and middle income countries. If you compare it with the India, and the difference is quite significant in case of tuberculosis, self-harm, and chronic obstructive pulmonary disorders. When we discuss about the case fatality rates in coronavirus, it is imperative we discuss about the case fatality rates of tuberculosis and dengue. We are on the verge of getting the dengue cases right now because the rainy seasons are already started. So tuberculosis, the case fatality rate is almost 17%, and untreated tuberculosis cases, it can go to 40%. We have 1,232 deaths per day because of tuberculosis. For dengue, the case fatality rate is 2.6%, although it differs in different uh, regions of the country. It is 2.6%, but if the care is given in even in the severe cases, if the care is given early, it can go to less than 1%. In the typhoid, what I would like to uh, focus upon is the E structure. So in the coronavirus, as I told before, that the youth and the children are The mortality rates are not that high, but in the typhoid, wherein the vaccine is available and most of the children are not vaccinated for typhoid, the death rate is quite high among the younger population. If you look at the global prevalence of typhoid, India is uh, the mortality rates are quite high in India as far as the global map is concerned. Now, two factors that I'll take your attention to is the age structure, the median age, and the proportion of people who have the overweight or the obesity. So, the definition of overweight is if your body mass index is the ratio of your weight and the height. If it is more than 25, then it is called as 20, then it is called as overweight, and if it is more than 30, then it is called as obesity. So if you look at the developed countries, USA, Italy, France, UK, and Spain and Sweden, the median age of the population is quite high, uh, somewhere around 40, 45 in most of the countries. Whereas the obesity, almost 70% or 60, 65% of the population are overweight or obese. Wherein in India, Bangladesh, these are the two countries I've chosen from the Asian peninsula, apart from Japan, and Ethiopia and Kenya. If you look at the median age and the overall obesity, uh, the median age in India is 28, Bangladesh 27.6. Overweight and obesity proportion is almost 19, which is far less in Asia as well as Africa. If you look at the Ethiopia and the Kenya for that matter, you'll get the idea. And now if you compare the deaths per million, USA has got 401 deaths per million, Italy 577, UK 652, Spain 607. So the deaths per million in these countries are quite high as compared to the India, Bangladesh, or the other African countries. In India, it is currently 15, Bangladesh 13, Ethiopia is zero point 0.9, and Kenya 3. And the last column is the test per million. So even in the countries wherein the high proportion of individuals were tested for the coronavirus, the deaths per million has not changed quite a lot. So if the France doing 21,200 tests per million, the deaths per million were 458. In if you compare UK and Spain, 1,56,000 uh, tests per million, and the deaths per million was 652. If you look at the Japan, Japan has not tested quite a lot of people. Still, the uh, deaths per million were just 8. So testing again, we'll have to look at the. I'm not trying to come to a conclusion based on this table, but what was important is to look at the data and the trend that it is trying to show. So even with the less testing, can we resort to, so testing can definitely give us the confidence of control over the situation, but the data suggests that it's not completely different because what matters is the deaths per million, and Japan is clearly an exception in this context. I have not highlighted Sweden and Japan because these were the two countries which had not imposed the containment strategies. So I leave it to you to come to an opinion based on your understanding of this data. So what were the key concerns? Again, a testing. How should we proceed? So testing can definitely be a fruitful in diseases which can be eradicated, especially diseases like smallpox. And second thing, in diseases wherein the proportion of asymptomatic individuals is not that high. Here in the almost 80% of the people have the asymptomatic infections. So testing will definitely be help us, and considering the, and then based on that we are going to do the contact tracing. So the whole exercise has definitely uh, used a lot of resources. That's the key concern. The it's not the efforts but the resources that we have to put in for these policies is something that is worrisome for us right now. Most of the states, Supreme Court also stated the emphasis on the home quarantine. So most of the states and the district administration are now resorting to the home quarantine policy for the asymptomatic and the mild symptomatic patients, trying to exempt those who have the comorbidities, especially the uncontrolled comorbidities from this thing. Herd immunity, there are a lot of debates going on whether it's possible or whether it's not possible. As we have seen in the New York, it was despite of the full-blown infection, 21% of the population was infected, wherein in Santa Clara County, which is quite scattered, just 2 to 4% of the population is infected. So I'll not go into details of, so herd immunity is some subset of population. If that population or the cohort is infected, it will definitely protect the rest of the population. So that's the concept. But it's not just that you have to go to a certain extent, like 60, 70. We don't have the number right now. But even whatever cohort is infected will definitely protect the rest of the cohort. So at least some level of immunity. Let's assume 20% of immunity will definitely protect rest of the 10% or 20% people, if not 100%, because we do not meet each and every individual. So whatever level of immunity is definitely helpful to protect some subset of population, and if that is uh, s- if we have to wait for, let's assume 50%, 60%, that then we cannot plan our policies based on that. That is something that's not in our hands. But it's for sure that some level of immunity will definitely, no, the immunity amongst the population will definitely help protect some subset of population. We are waiting for the vaccines, but recently WHO Chief Scientist Soumya Swaminathan has raised a lot of concern about the ethical standards of the fast trials, and it's not what she was postulating is that it will take another 1.5 years for the vaccines to come. But what is equally important is not just when the vaccines will come, but it's, uh, who will get the vaccines is also one of the concern, because the global supply chains have turned towards the countries with the money. When the remdesivir stocks, initial stocks were bought by the US, or for that matter, the ship carrying the, or the plane carrying PPE kits to, from China to Germany was diverted towards the USA because they needed it most. So whatever. So we'll have to look at the global scenario uh, according to the level of classes that have been created through the global supply chains. So it's not just when we'll have the vaccines, but who will get it. Among now in the India itself, there will be the categories who will get it first. So that's something worrisome considering the prevailing inequalities we have, not just at the regional or national level, but the global level. Now, another factor that is under debate is the when will you have the peak, or when will we flatten the curve. So ideally, there cannot be a single peak. The peak will be there, but it will be in the different cities. So if Mumbai, or for that matter Pune, will be infected, or within the city itself, different parts of the city. So let's assume that one part of the city is full blown, then another part of the city will pick up, then the within city will have a different peak. So, so you will have to try and understand that these options are not there with us right now. We'll have to live with the virus, which is not that severe. Now, based on the data that I've shown, the virus is not that severe. It's not affecting the children and the healthy youth, or for that matter, healthy elderly population. Most of the people who have controlled diabetes, controlled hypertension, have been cured of the disease. Even the 93-year-old uh, elderly population have been completely cured because from the disease. So we'll have to try and understand that we'll have to live with the virus and the herd immunity vaccines and the other containment strategies that cannot be the option with us. And there's no need also because uh, the virus is not that severe. Of course, if we had a good vaccine, because that is something that is not is going to be a tragedy. But if we could have a vaccine, good vaccine, we would have definitely incorporated that into the our implementation strategies. But it takes a lot of time to develop a new vaccine, and compromising on the ethical standards or the safety standards is not good for the community itself. So we'll have to live with the virus, which is not that severe, is the concluding statement for this slide. And the way forward, I'll only emphasize on the introspection part. We'll have to introspect of whatever is coming to us. So whatever news or the data or the evidence that is coming to us, we'll have to introspect. We'll have to introspect why we are afraid of this disease. What's the knowledge that we'll have to gather about the disease, and after that we can decide on our own what will be our stand, especially for the educational institutes. It creates a lot of onus onto the institutes now to create a social responsibility as part of a curriculum, because of the because we'll have to develop a sense of responsibility among the students for the society itself, and that's the reason we'll have to introspect. uh, we do not have enough information about the virus, and we'll have to track good sources of knowledge and create some accountability into our institutions, wherein if they are not delivering enough knowledge to us. So that's it from my side. Thank you so much.